I'm Dr. Brian Haas, founder of Hospice Intelligence, an AI-powered documentation platform that helps nurses and physicians create Medicare-compliant hospice notes by checking against LCD criteria in real time, reducing audit risk and burnout. This week, I wrote about one of the most challenging aspects of hospice documentation: caring for patients who don't fit neatly into disease-specific LCD categories. You know these patients. The person with advanced Parkinson's whose swallowing has failed. The trauma victim whose family chooses compassionate extubation. The patient with inflammatory bowel disease who suddenly develops overwhelming sepsis. These cases keep compliance officers up at night, and for good reason. Without clear LCD criteria to follow, denial rates for these non-disease specific cases are nearly 3 times higher than patients with established guidelines. You've probably seen this scenario. A patient arrives with advanced Parkinson's disease. They're clearly appropriate for hospice. They're unable to walk, aspirating on liquids, losing weight despite your best efforts. But when you sit down to document, you realize there's no Parkinson's LCD, no checkboxes to follow, no clear roadmap. So what do? This is where Part 1 criteria, those non-disease specific baseline guidelines, become your documentation lifeline. Let me share what I've learned from reviewing thousands of these cases. First, you need to understand that Part 1 criteria focuses on universal markers of decline, regardless of diagnosis. Think of it as your safety net when disease-specific criteria don't exist. The cornerstone is functional decline, documenting a PPS or a Karnofsky score below 60%. But here's what many nurses miss. You don't just write PPS of 40%. We have to paint the picture. The PPS declined from 60 to 40 over 3 months. The patient now requires a 2-person assist for all transfers due to severe bradykinesia and postural instability. It's really important that we describe what the changes in the PPS are. The second critical element is nutritional decline. You need either documented weight loss exceeding 10% over 6 months, or lab evidence like albumin below 2.5. But for neurodegenerative conditions, the why matters as much as the what. Instead of just noting dysphagia present, document this. Modified barium swallow shows aspiration with thin liquids. Patient requiring a puree diet with honey-thick liquids. Meals now take 45 minutes to complete. Weight decreased from 142 to 124 pounds over 3 months despite speech therapy interventions. Do you see the difference? You're not just checking boxes. You're telling a story that any auditor can follow. The third piece that often gets overlooked is healthcare utilization. Multiple ED visits or hospitalizations for the underlying condition demonstrate that we've crossed from manageable to unmanageable. This is especially powerful for those acute catastrophic events. In my experience as a medical director, I've seen how these non-disease specific cases challenge even our most experienced nurses. I remember one particular case, a 42-year-old construction worker with a traumatic brain injury whose wife chose compassionate extubation after 5 days in the ICU. The nurse asked me, "How do I document this? He was working last week." That's when I realized we needed a different approach. These acute transitions require us to document not just the current state, but the irreversibility of the decline. We ended up writing, despite 5 days of ICU level care, including mechanical ventilation and vasopressor support, the patient shows no neurological improvement. The EEG confirms no cortical activity, and the family is choosing comfort care after extensive discussion of prognosis with trauma as well as neurology teams. Working with hospice teams across multiple states, I've identified 7 hidden documentation gaps that trigger denials in these cases. But the biggest one, failing to document why standard treatments won't work. So for Parkinson's, you might write, while levodopa typically manages motor symptoms, the patient has developed medication-resistant freezing episodes. Deep brain stimulation is contraindicated due to cognitive impairment. You're explaining to the auditor why this isn't just Parkinson's. It's end-stage Parkinson's, where curative options have been fully exhausted. Now, this complexity is exactly why we designed Hospice Intelligence to provide real-time guidance for these challenging cases. When you're admitting a patient without clear LCD criteria, the platform doesn't leave you guessing. It prompts for those Part 1 criteria, helps you to connect diagnosis to prognosis, and ensures you're capturing condition-specific markers that matter. Technology should support clinical judgment, not replace it. When a nurse is caring for that Parkinson's patient at 2 a.m. and documenting decline, they shouldn't have to remember every possible element. They need intelligent support that ensures nothing critical gets missed while they focus on providing compassionate care. That's our vision at Hospice Intelligence. Empowering nurses to document with confidence, even in the most complex cases, so these patients get the care they deserve without the constant shadow of audit risk. Here's what I want you to remember. Every patient deserves hospice care when appropriate, regardless of whether their diagnosis fits neatly into an LCD category. Your documentation is their lifeline to receiving that care. Focus on painting the complete picture: functional decline, nutritional status, healthcare utilization, and most importantly, why standard treatments won't change the trajectory. Connect the dots between diagnosis and terminal prognosis. Now, to all those hospice nurses that are out there watching, I know documentation feels overwhelming sometimes, especially for these complex cases. But remember, you're not just filling out forms. You're advocating for your patients through your clinical narrative. You're ensuring they receive the compassionate end-of-life care they need. Thanks for watching. I'm Dr. Brian Haas with Hospice Intelligence, helping hospice nurses and physicians document with confidence, compassion, and compliance. If you'd like to dive deeper into this topic, check out this week's LinkedIn article linked below, where I explore specific documentation strategies for Parkinson's disease, trauma cases, and acute catastrophic events. Keep doing the incredible work you do for your patients and your families. They need you. Thank you.